All right, it's time for marijuana. So I'm going to talk about a bunch of different topics today that is really easy for me to go, this is bad. Meth. You will not see me waver on meth at all. Meth is bad, right? Marijuana is interesting. It's one of those topics that can be very heated. It can cause heated conversations. And so we're going to talk about marijuana in a number of different ways. What we know about marijuana, what we don't know about marijuana, how it affects dentistry, and maybe some good things about marijuana as well. The message I want to give to you is I have existed as a hygienist in every type of marijuana situation there is. In other words, I started practicing in Wisconsin where marijuana was not legal at all. In fact, it's still not, no marijuana. Like here, right? Marijuana bad, here, according to the law. I've practiced that way, and I've gotten to experience marijuana conversations with patients in that system. I came to Washington when medical marijuana was the only thing that was legal. And I got to practice as a hygienist during that time. And now marijuana is everywhere, all right? And totally legal. I mean, you can only sell so much and grow so much, but I mean, that you can get in trouble still, but it's pretty much legal. And I get to practice today in that atmosphere. And so I'm going to tell you my experience and my thoughts about the marijuana based on as a hygienist. So there's a lot of different street names for marijuana. I can tell you, I can guess your age within a couple of years based on what word you use for marijuana. Guaranteed. It's a skill. Reefer, dope, weed, Mary Jane. In our home, by the way, we call it the devil's lettuce. Jim started that. I don't know why, but every time Brad would leave for school, Jim would go, be good, no means no, and stay away from the devil's lettuce, like every morning. And unfortunately, it didn't work. We'll talk about that in just a second, too. So marijuana is a complex plant. And it's really funny because everyone talks about THC, marijuana, THC, THC. THC is just one part of the marijuana plant, but it's the part that gives us the effect, right? It gives us the effect that people are looking for when they do marijuana. We're going to talk about some other things that are in marijuana as it applies to this state. So this is kind of a map of everywhere. So in gray, you'll see not legal at all. I think it's light green, recreational use, and then medical marijuana is dark green. Right, so light green is pretty much all marijuana is good. And then here's our list of states. Maine has a question mark by it because I still think they're in deliberation. They actually passed a law, I think back in November, and there was such an just outcry of anger that this passed that they accused the poll takers of lying. And so I think they're still counting. I mean, it's like, what, April? And they're still counting the ballots for Maine. But this is pretty much the states that have legalized marijuana completely. So let's talk about Tennessee. So Tennessee is not the only state, as you saw, and there's this whole section of states kind of around you that have no legalized marijuana whatsoever. So some people I've never heard of, but I just did some research. They're really pushing for medical marijuana, actual medical marijuana in this state. Will it happen? Oops, sorry about that, is yet to be seen. What you guys do have is something kind of interesting. So you probably know this already. You probably know more about it than I do. They have a university-based cannabis study that they started in 2014. All right, so patients can be a part of this study. And this study, really, they primarily look at seizures. Like it's a very much a seizure thing. They do look at other things in the study, but it's very much a seizure thing. They use CBD. What CBD actually is, it's another part of the plant, okay? So THC has got like really high kind of psychoactive it's drug. This, they say non-psychoactive, and then underneath it in the fine print it says, okay, well, just a little. It's still a little. So what they do is they actually just, they pull that out, and how much THC that is in the marijuana has to be under 0.9% for this medical study that you guys have here, all right? So patients come in. Now the effect, the high that you get from the CBD is actually, it's very sedative, right? That's the effect that they're trying to get. So basically, you've got like marijuana light. You know, it's like the light version. And only for people who are in this study. Sorry. Okay. Will Tennessee legalize marijuana? Raise your hand if you think that Tennessee will legalize marijuana someday. Okay, raise your hand if you think that Tennessee in your lifetime will never ever have legalized marijuana. Raise your hand. Okay, there's always going to be some that say absolutely not. So I was lecturing last year in Dallas, and some young dentist was like front and center, and I said, so when Dallas has legalized marijuana, and he stopped me, and he goes, oh, no, Catrice, you're in Texas. We will never have any legalized marijuana. Do you know who now has legalized medical marijuana? Yeah, Texas. So this is the thing I'm going to tell you. We're going to have this discussion based on the fact that it is not legal, and then we're going to talk about when it becomes legal. Because mark my word, it is going to be legal here, all right? And I'm going to show you why. Now, this is a stat from New York. There was nothing for Tennessee, but this just gives you an idea of what happens in most states that have no legalized marijuana. New York pays $75 million to arrest and process drug possession. And I'm talking like misdemeanor drug carrying marijuana stuff. So this is what they spend to arrest and process people with a little bit of weed on them. This is what Washington made in the last, few years? 250, yes, that's $million in taxes on marijuana, all right? So like it or hate it, believe in it, don't believe in it, it will be legal, and this is the reason, all right? It just makes too much money. Forms of marijuana on page 4 of your notes. Okay. The most common way to ingest marijuana is still smoking. It's easy to make, it's cheap to make, and it's easy to get your hands on. Just because it's illegal here, you do know that it's still here, right? Like people still smoke marijuana even though it's not legal. Oh, this is the morning after Washington State legalized marijuana. This is what it looks like. Just to prepare you. Coming from Wisconsin, I grew up in the Midwest in the 80s in a place where marijuana was evil. It was the devil's lettuce, right? I grew up raised that, you didn't do marijuana unless you were bad. So those are values that were instilled in me throughout my entire life. And then I moved to Washington, and I'm like, dang, people, like, what's that smell? It is everywhere. It is everywhere. And so it's an adjustment of the way I've always thought my entire life, and how I deal with patients had to be adjusted based on the way I felt, the way I was taught. Oh, hookah. So here's your water pipe. The whole point is you actually you smoke it through a layer of water. What does that do other than make some slurpy weird sound? It removes some of the tar and irritants. It's supposed to be nice and smooth and make smoking a lot easier. Hashish is extremely popular in a lot of different ways, and we'll talk about the ways that they use this. So what they do is so you've got this beautiful plant, right? You got to admit, it's really kind of pretty. So there's this pretty plant, and there's leaves, and then there's the bud. And the bud is where all the THC, not all, but most of the THC is kind of sitting in that bud, right? It's where it's at its strongest. So what they do is they discard the leaves, and then they use a whole bunch of different processes, from chemical to mechanical, and they use these processes to actually extract the THC. And so what ends up happening is you get a product that is really, really pure and really, really strong. Very delayed effects with this type of marijuana, but very profound and long, long effects. This is one way that you can see it. To me, it looks like zucchini bread, but that is actually marijuana. You can tell I'm from the Midwest. It's solid or resinous, and it's pressed kind of hard in texture. And it looks like something that would be tasty with butter. 5 to 10 times stronger than your typical weed or that typical plant. So remember this when people are using hashish. It is much, much stronger. All right, bubble melt hash is extremely popular. This is the stuff that they use in a lot of your edibles and a lot of the products that your cancer patients or your medical marijuana patients will use. And it's kind of pasty in texture. Again, 50% more THC because they've extracted all of that THC. They've gotten rid of kind of the filler, and they've made this stuff really strong. And again, it's a very delayed, profound, and prolonged effect. Bubble melt hash. So when I started researching bubble melt hash, I heard bubble, and I thought that bubble melt, they boiled it somehow. That's not actually how they make it. They actually put it in ice, and they let the THC kind of raise to the top. They kind of sieve it off the top, and then you've got very condensed THC. I'm not going to spend a lot of time with this, but these are all the different methods that they use. There's like ice bucket, not the ice bucket challenge, but the ice bucket marijuana method, two different things. They have heat pressure separation, static electricity sieving. I mean, this is a really big industry. Acoustical dry sieving, this is how they extract the THC. Dentistry. So let's talk about dentistry. No strong evidence that marijuana causes increases in oral cancer and periodontal disease. No strong evidence. Why is that? And is that a true statement? No. So the reason why we can say that is because there is no strong evidence, research support, okay? Does it probably do those two? Yeah, absolutely. They're more and more. In fact, new articles are being written about periodontal disease and marijuana. The reason we don't have a lot of evidence is because it is and has been illegal. And it's really, really hard to get patients to come in for studies on a drug that is completely illegal, right? So we don't have a lot of studies. And then clinically, what we have is patients we know that use marijuana, but they're also smoking. So when they get their lung cancer or they have periodontal disease, a lot of times they're using both products. And so how do you determine how much of that lung cancer is from marijuana, how much of that lung cancer is actually from cigarette smoking? But this is an interesting article in the Journal of Perio. If you guys want to take a picture, you can. It's March 2017, so a relatively new article. It actually wasn't written March 2017, but it was updated. I think that it was written last year, but it was updated in March of this year. Kind of an interesting article because if you actually read it, and it's a scientific article, so there's all kinds of percentages and there's a lot of information. And so if you sift through the information, basically what they said is they have found slight increases of periodontal pockets in patients who use marijuana. In fact, this article, in June 2016, people who use cannabis for up to 20 years may be more likely to have periodontal disease. Wow. That's a big statement. So again, they don't really know a whole lot yet, and they won't until we start actually doing some good research. What we do know are these things. Marijuana increases xerostomia. For any of you who have illegally smoked marijuana, don't raise your hand. The video camera's going. So don't raise your hand. So, but for those of you, because I know some of you have, they talk about marijuana and dry mouth. Okay, so I grew up marijuana bad, right? But in the name of research, it didn't seem right to lecture on it and really not know anything about it. So 2 years ago, I decided to do some research. I'm not kidding. So I made it 45 years never touching marijuana. But for you, and only you, I tried it. You're welcome. So anyway, so for a very green marijuana person, I will tell you that the dry mouth that they talk about, like they talk about cotton mouth and the things that happen, it is very real, okay? It is very real. I empathize with my cancer patients who've gone through chemo and radiation and all their xerostomia, and I'm like, that's what that feels like. It's awful. So anyway, increased xerostomia, which increases decay. Tachycardia, we have to be careful with patients with local anesthetic, especially surgeons. I talk to oral surgeons all the time, and they're like, yeah, we're really trying to get them to, to lay off the marijuana as much as they can before we give them local anesthetic. Another thing that we do see is more candidiasis with patients who use, who do smoke marijuana. They actually have a higher risk of yeast infection than patients who smoke tobacco cigarettes. And then green stain on the tongue and teeth. Okay, just so you know, that's not actually what they look like. I couldn't find a picture of the green stain. So, but that is what the tongue looks like. How many of you have seen the marijuana green stain on teeth, right? And when this happens and you say to your patient, do you smoke? And they go, uh-uh. And then do you say, you don't smoke marijuana? And they're like, oh, no, because they're not going to tell you, for the most part. How many of you have had patients admit it? Okay, awesome. That's actually not bad. I mean, it's not as much as I'd like to see, but it's not bad. It's because it's illegal. Once it's illegal, things will change. But what I'll tell you is when you ask patients about this stain, I just had this happen. It was probably about 4 months ago. It's my favorite story yet. Young man, green stain all over, especially linguals. And so and it's legal in Washington. And I said, oh, do you smoke? And he's like, no, not at all. And I'm like, you don't smoke marijuana? And he goes, no, I don't smoke. And I said, wow, you have a lot of stain that's, it's very green. And we see that a lot of times with patients who use marijuana. And he goes, no. And he sat for a second. He goes, I drink a lot of green tea. Sure you do. We'll go with that. But let me tell you the effects of marijuana while we're, just for fun. So anyway, you will see stain on your patients. And sometimes it's a good way to kind of open up that conversation. All right. So this is the confusing thing about marijuana. Marijuana, they have proven that marijuana causes lung cancer. Okay? Cancer in lung cells. They have proven this. So if there's one thing that you want to put in your back pocket for your patients, no, we don't have proof about perio yet. We don't have proof about oral cancer yet, but we do know that marijuana has been linked to lung cancer, okay? So that we've got. However, lab tests using marijuana have shown to kill brain tumor cells, okay? Brain cancer. Marijuana has actually killed brain cancer cells. So, why is it hard for me to go, oh, marijuana bad? Because the things that they're doing in researching medical marijuana is actually incredible. It's really interesting. So let's talk about the effects of marijuana. Understand I pulled this from research, and we're going to talk about it in detail in just a second. So here are all the bad things that can happen to a person. This is what they suggest that happens to people who use marijuana. You have a risk for addiction, more car accidents, bronchitis, diminished lifetime achievement, depression and anxiety, low level of self-confidence. Do you hear the mocking in my voice? Lower IQ, impaired short-term memory. So let's pick this apart. In Washington and Colorado, there are actually less fatalities since they've legalized marijuana. Now, the people who are in favor of marijuana credit marijuana for these less car accidents that we're seeing. Maybe people are just getting baked at home and they just don't leave. Like, I don't know. I don't know what it is. But in our 2 states, there's actually less car accidents. Maybe they're drinking less and smoking more. I don't know. So understand that They state that this is true, but it hasn't been proven to be true yet. This is my favorite. People who use marijuana have a diminished lifetime achievement, low level of self-confidence, and lower IQ. How many of you agree with that as a standard statement? So the most brilliant man I have ever met, director of a high-tech data storage company, dude's wicked smart, baked all the way through high school, college, and to this day, in his 40s, is a regular marijuana user. Smartest man I know. So do not, and the reason I'm saying this is, when you have the opportunity to talk with your patients about marijuana, and if you come into it with my background of marijuana is bad, marijuana is evil, and the people who use it, not my people, you're not going to get far with your patients. You're not going to get them to be honest with you. You're not going to get them to open up to you. And you're not going to get very far with good communication about their health. So what I'm saying here is, this isn't standard, because I know a lot of people who use marijuana who make 5 times the money I make, highly successful, raising their children well, and they're okay people. And so when we're talking to our patients who use marijuana, just assume they're an okay people, all right? Let's not put them in that category. And then risk for addiction. So I studied psychology. I have an undergraduate degree in psychology, so I know like this much, right, about it. And my concentration was addiction. So what do we know about addiction? Because I talked to a lot of people about, marijuana, and it's highly addictive, and people get addicted, and they're so worried about this addiction thing. Does everybody who smokes marijuana get addicted? No. Does everybody who drinks become an alcoholic? Does everyone who uses meth, actually meth is a bad example, because it's really hard to get off of meth. But anyway, so the point of this is, not everybody who uses marijuana will become addicted. That's what we know about addiction is, if you smoke marijuana every single day for the next 6 months, and you do as well, you might become addicted, and you won't. It's just the way it is. So just because people smoke marijuana doesn't mean it's an automatic and it's not, and people talk about the gateway drug. For some people it is. I've heard stories, some people it is. It's highly addictive for some people, just like alcohol is, just like tobacco is, right? Okay, medical marijuana. So it's the things that they're doing with medical marijuana is what makes me go, okay, settle down. They're actually doing some good research on medical marijuana. This, by the way, is pictures from Colorado. They're vending machines. I don't know if you can see that. So they actually have marijuana in vending machines. Now, before you all book a ticket to Colorado to go get your marijuana from the vending machine, you actually have to have a medical card to access one of these vending machines. But it doesn't matter because you can get marijuana anywhere anyway. So let's talk about the good stuff about marijuana. It stimulates appetites with people with AIDS and chronic wasting syndrome. So for people with AIDS and chronic wasting syndrome, this is survival for them. This is the only way that they are able to even eat and not be nauseous and not be sick all the time. Same can be said for our chemotherapy patients. I suspect that most of us have seen chemotherapy patients, right, who are sick and nauseous, and you've watched what medical marijuana does. It's kept them healthy enough to receive their treatment and beat their cancer. So it's a really necessary thing. The spasticity thing is kind of interesting because it ended up being an effect of marijuana that they started researching later, and we'll talk about some of the new fun things that they're researching when it comes to medical marijuana and spasticity. Reduces inflammation, rheumatoid arthritis. These are all the things that are on your medical cards, right? Crohn's disease, colitis. In 2017, and probably for the last, I'm going to say 3 or 4 years, the biggest research with medical marijuana has been in the areas of spinal conditions, chronic pain, seizures, and post-traumatic stress disorders. Huge, huge benefits that they're seeing. How many of you have seen the videos of the seizures, right, and what medical marijuana does for patients who have serious, chronic, lifetime seizures? So growing up, marijuana bad. The more I learn about medical marijuana, the more I understand that I think it's a really important thing we need to research. And I'm going to introduce, this is my dad. And the reason I'm showing you my dad and introducing his story to you is my dad has a spinal condition. The interesting thing about my dad's spinal condition, the thing that I find interesting, is it happened when he was 42, all right? And I remember I was a young adult, and I remember him starting to lose the ability to walk. He lost his balance, lost his mobility. And I remember saying, well, thank God it happened when he was old. He was 42. I'm now 46. And I remember saying that. I'm extremely active, and at 46, I can't imagine not being able to walk. I can't imagine having a condition that changes my life in that way. So I've watched my dad lose the ability to walk with his spinal condition. I've listened to the pain, the chronic pain. So understand, spinal conditions are really interesting because these patients have chronic, excruciating pain and numbness all at the same time. Like, how does that happen? They seem two very opposite things. So for him to be able to control the pain, he has to take what? He's in Wisconsin. Lots and lots of narcotics. Prescribed, by the way. So they're okay, right? They're totally healthy for him. Opioids. 30 years of layered opioids are really good for people, right? Okay, so my point is, I've watched my dad take 30 years of medication to control the pain, which gives him no strength, so now he can't walk at all. So he balances pain with mobility. And I've watched this, and I read all of these great things that are happening for spinal condition patients, and all I think is, man, I wish my dad could get his hands on some marijuana. You know, like I want him to be out of pain. I want him to have this, and I know how bad those pills he's taking are for him. And my mom says, when I said, you know, you should take him to maybe go to a state that has medical marijuana, maybe see if you can get some marijuana for dad. And she said, absolutely not. I am not going to allow your dad to be on marijuana. But she lets him take narcotics every day. That doesn't seem to bother her at all. So anyway, this is my dad today with his two pups. And I'm going to tell you one more little story just because you're stuck. Because I have the mic. My dad is being honored next month. He has been chosen to be a part of the honor flight. Have you ever heard of it? They bring veterans in and they take them to DC, right? Mm-hmm. Guess who he chose to push him around in his wheelchair for the day? Yeah, pretty excited. Okay, so let's talk about how they use marijuana today. Marijuana today is not necessarily smoked. They're chocolates, they're bonbons, they're little ice cubey things. That little liquid, you guys have water enhancers, you know, like Mio and whatever, like Kool-Aid stuff. They make stuff you can literally drink your THC. It's amazing. You see these? They're chocolate mint, and they're absolutely delicious. Again, in the name of science, I have researched this for you. Now, I joke a lot about this research. I have to tell you, marijuana is not my thing. Like, I don't get it. I literally researched it just so I'm not an idiot standing up here talking about something I've never actually done. So I have eaten some chocolates. And again, I'm not going to ask you if you have, but would you like to hear the story about my experience? Yes. Okay. Good, because I'd love to tell it. So I'm from Wisconsin, and I know drinking, and I know how that feels, and I know nothing about marijuana because I spent my entire life, childhood, teens, and adult life, not ever coming anywhere near this stuff. So I don't smoke, and I won't smoke. So I'm like, well, I can eat chocolate, though. I mean, that's how bad can that be? It's chocolate. And so with the help of Jim, we went out, we purchased some. These places they're not sketchy. They're actually very high-end. They help you purchase just the right kinds of chocolate. And so we went home and we sat on the deck and I had my piece of chocolate and it was absolutely delicious. And I remember sitting there going, well, that's a waste of money. There's nothing going on here. This is, I didn't know. And so I had another one. So just so you know, there's about 10 milligrams of THC, of marijuana, THC in in one piece of chocolate. So I had 20 milligrams, I had 2. And I'm sitting there and a few minutes goes by and I'm like, seriously, people pay money for this stuff? Like, I don't get it at all. So I had another one. And then another one and another one. Because they're so yummy. Okay, so this is how it went for me. There's apparently phases of high that happens that you kind of move through. I missed them, all of them. I went from, this is the biggest waste of money, to, I think there's a government agency coming after me. And I have a fever in my face, but only my head. And I took my temperature that night every 10 minutes for 4 hours. Because I was sure, and I told Jim, you have to stay up because I might die tonight. And you need to make sure you watch for warning signs of death early day, because it's going to happen. You got to take me to the hospital. That was my experience. No, I've heard other people really enjoy it. So if you're going to try marijuana, don't do it like that. It is not how you do it. You're all like, duh, I wouldn't have done it that way anyway. So don't start with 50 milligrams. It's just a little too much. So anyway, I've not had a good experience, and so I've just never gone back. But for research for you, there's my story. All right, so discussing marijuana. It's complex here. It's illegal. I mean, you guys raised your hands, and I'm so glad that some of you have had these conversations with your patients, because for them to actually be open and honest with you, for those of you who raised your hand, good job, because the relationship you developed with that patient to have that communication take place in a place where that is illegal, fantastic job, all right? Because it takes a lot of trust to have somebody actually admit that in a place that you're not supposed to be able to do it. I'm going to tell you my experience as a hygienist. In Wisconsin, we never talked about marijuana. Even when I suspected it, I didn't know how to bring it up. It was very difficult. When I finally did bring it up, people lied to me. Every single time they lied to me. So it wasn't very successful communication. Then I moved to a state where it is legal. So I'm going to tell you my feeling of marijuana. I can't wait till it's legal everywhere. I cannot wait. And I know some of you are like, really? Because I totally don't agree with you. I think it's terrible, and I think it shouldn't be legal anywhere, ever. I can't wait till it's legal, because the communication I have with my patients right now is stellar, because they don't lie to me as much. They still lie to me. Do you floss every day? Every day. Really. So they still lie to me, but they're more honest. And when I say, do you smoke? They'll say, I actually had this happen to me last week. Stomatitis. By the way, you still see stomatitis with marijuana. So I'm just seeing tons of ridgy stomatitis everywhere. And I'm like, and this is a new patient to me. I've never met him before. And I said, so do you smoke? Now, mind you, going into that conversation, I could smell that he smoked, and I knew exactly what it was. There was no doubt. I think he was smoking up until he got there. I said, do you smoke? And he said, not cigarettes. And so that's how he said, and I'm like, oh, cool, okay. So let's talk about that. How much do you smoke? And so the cool thing that I love about marijuana legal is I can sit with somebody and now go, all right, that's good to know. How much do you smoke? How long have you done that? Well, this is what we don't know all about this yet. We're suspecting this to be true, but what we do know is it does increase your chances of getting lung cancer. So I need to tell you that, just so you know. And so it opens up communication that I never had before. So very excited for every place to be eventually legal. Things that you need to know. It is not legal here. We already know this. And because of it, some of you especially, we were raised to find this to be bad. And we really need to work on how we communicate with patients. And so go into it with the least amount. Well, here we go. People are embarrassed to tell you. People are scared to tell you. You have to be non-judgmental, all right? So practice it in your mirror if you have to, because people will see right through it if you're not honest. You have to treat these people with respect, and if you don't, they will not communicate with you. Non-judgmental attitude, discuss the facts. I do that with like every kind of sketchy topic where I'm like, oh, people aren't going to take this well. It's kind of a matter of fact. Here's the deal. This is what we know. This is what we don't know. I'll keep you updated when I learn new things, but this is what's important for you to know for your health. And provide resources if you can. How many of you do that with patients? I'll find like really great research articles and I'll print that stuff out and I'll keep it, again, in my back pocket because you have some analytical patients that pick apart everything. They love those articles. So feel free to print those resource articles out for them. And then again, when you have your hands on your notes, you have some marijuana resources. Any questions, concerns, worries? How many of you are, yes, do we have, do I send my dad chocolates? No, it's funny, I wish I could, but it's not legal at all, so I think I actually could get into trouble bringing him chocolates. So it's funny, it's like just because you buy them someplace legal doesn't mean you can like pack a suitcase full of marijuana and go, hey, Mom, Dad, here we go. So no, I don't bring him chocolates. I don't, and I try to have good conversations with my mom of, so these are the medications he's taking, and she saw it firsthand. He had a heart attack 2 years ago, and it was really, it was really scary. The doctors in the ER took him off all of his medications because they need to balance out the heart meds, right? They need to figure things out. And so they took him off 30 years of narcotics, like that. And so we still talk about how Dad told us stories about the bunnies humping in the corners and the snakes coming out of the walls and how he thought he was in prison and not the hospital. And so he went through some serious withdrawal. So I think my mom understands that. But no, I can't bring him chocolates. It's unfortunately illegal. Yes?
They say that the CBD oil is not so psychoactive, but
right.
It has lots of health benefits. Could you talk about that?
Yeah, so what I know about CBD is it's parts of the cannabis, there's like 40 different parts, right? So THC is one of them. CBD is another, and there's a whole bunch of other ones. But the ones that they focus on are THC because it has the biggest effects, right, for pain management. It gives you the high. CBD is just another one. It's the same part. It's just a different part. Like I said, it's one of 40. I found this really great research, and if you email me, I will say, I don't have it, and it's big research, but I found some really great stuff on CBD that I just started to read, and I'm happy to send it to you. And not just CBD, but all of the other little pieces of marijuana that they have, they don't use because it doesn't give that same pain control. So basically what I know about it is it has small effects. It still gives you a high, but the high is much more sedative. Does that make any sense? But again, email me. And if any of you are like, oh yeah, send me a bunch of stuff on CBD, I literally just downloaded this great article that I haven't had a chance to really dig through, and I'm happy to send it to you. So remember, please do that. Any other questions? Good? All right. Everybody's doing okay? What time is it? So they say that we have till like 6 p.m. No? Dang. We're doing great. So I think we have until 1 o'clock. So here's what's going to happen. We're going to not take a break just yet. Feel free to go to the bathroom if you have to. We'll take a break in just a little bit here, though. We're going to start our next topic. And we will be done by 1 o'clock sharp. All right? If there is something I respect is your time, I will not go over. If I don't feel like I got through everything I'm dying to tell you, I will make sure that it gets uploaded to the app, and you guys will have your hands on everything that we don't cover. But I believe that we should not only be done by 1, we might even get done a little bit early. If we get done early, this is what I'm going to tell you. If there are questions, because this is a big group. You guys have gone to other CE, right? Where there's like 40 to 50 people. It's a lot easier to ask questions than when you're in the back of the room. Hi, guys. Way back there. If you're in the back of the room, it's really hard to ask questions. So I'm going to try to get done a little bit early so I can stay and answer questions, and the rest of you can enjoy this gray, kind of crappy day. Looks a lot like Seattle right now, actually, but much more humid. By the way, how do you guys handle your hair here? Like, my hair today has got this Tennessee thing going on, and y'all look so good, and I look terrible. All right. For our next topic, we're going to switch gears. We're going to move away from drugs, and we're going to start talking about the sex stuff. And I don't know why it is, but whenever I get to the sex stuff, I feel like I have to take my shoes off. I don't know why that is. Oh, man. Oh, right? I love that you guys don't like shoes either. Who makes those things? Okay, so here's the deal. So we're going to talk about HPV. Can you guys still see me back there? So we're going to talk about HPV, and I understand that some of you were at a program, I think it was just last year, and the speaker talked about HPV, and I got to see a couple little snippets of his talk. So for some of you, some of this is going to be some repeat information. Hopefully some of it is maybe a different perspective. For the rest of you, because there's a good 400 of you who weren't here last for that session, that this may be new. So raise a hands. How many of you have seen an HPV talk, HPV oral cancer talk? All right, so not as many as I thought. Fantastic. Oh, by the way, if anybody wants to take a picture so you can send to your husbands and wives what you're learning today, feel free. Okay. It's the picture that shows up on the internet most often. Okay, so page 6. There is not a whole lot that someone can tell you that is scarier to hear than you have cancer. I mean, I've yet to find a statement that packs a punch like you have cancer. So 20 years ago, as a brand new hygienist, about a year into practice, I had what I would call my first cancer patient. Now, we had patients with suspicious lesions. We sent them out for biopsies, but she was my first real cancer patient. We're going to call her Diane. That was her name, and it makes it so much easier. So Diane came into our practice. I worked in perio, all right, for like 17 years. And so perio is different. Any perio hygienist? Any periodontist? Awesome. Perio group, perio. So in perio, like in general practice, you guys don't see patients. You see families. You see tribes, right? If you're good, you see mom, the kids, Uncle Joe. You see big groups because they refer their family to you. So the relationships that you develop with your patients are totally different. In a periodontal practice, we get the patients that you allow us to see, right? That you send to us. So they're very individual. However, in Diane's case, I actually saw her younger brother. We were the only office in town that saw special needs kids when they were kicked out of the pediodontist office and they had nowhere else to go. So her brother had Down syndrome and had been a patient of mine for many years. So Diane came into our practice, and she was there because she was referred to our office. She had been diagnosed with stage 4 squamous cell carcinoma under her tongue, and I'm not even sure I can make a lesion with my hands as big as what was where her tongue used to be, but it was an enormous advanced lesion. And she came in and she spent half a day with me, if not more, because my job with Diane was to get her healthy enough, get her mouth clean enough to be able to be successful in her cancer treatment. So I spent an entire morning plus with Diane, got to know her really well in that amount of time. My other job was to help her understand that every single treatment for cancer, all of those side effects that come with it are amplified by bacteria. And so my job was to teach her how to maximize her health during her cancer treatment. So I spent the day with Diane, and like 20 years ago in most places, and especially in Green Bay, Wisconsin, when people sought out cancer care, it was not like it is today. Do you notice that we see a lot of cancer patients today, but we didn't 20, 30 years ago in our practice? There's a reason for that. Because 20, 30 years ago, when somebody had cancer, they were shipped away somewhere to some cancer center. They sometimes left their families and they went away for months and months at a time. And so you wouldn't see them during their cancer treatment. There are fantastic cancer care facilities all over the place. And so people are seeking cancer care right in their backyard. How awesome for them, right? What that means is we see them more often throughout their care. But in Diane's case, she went away for her care. In fact, I think she went to Mayo Clinic. So if you know, that's in Minnesota. So it was a long way away. So I didn't see her for a year. Diane came back into our practice after surgery, tissue graft, chemotherapy, and radiation. Lots of it. And if you've seen oncology patients after their cancer treatment, especially extensive cancer treatment, you realize that it's a mess, right? Xerostomia is a real thing when it comes to cancer patients, especially head and neck cancer. And she had absolutely no saliva, and there was tons of problems, decay and periodontal issues. She was a mess. And as a new hygienist who never experienced anything like this before, I really didn't feel equipped to help her in the way that I wanted to. So what I did, and I just saw a patient the other day that I had this feeling kind of sneak back. Have you ever had that patient where the treatment plan and the mess is so big, you kind of have to stand back and go, I don't even know where to start. Like I don't know what phase 1 is. So we chose a phase 1, and we started working toward it. We started with new home care tools and really started the education process. Got her clean. 3 months later, she came back, and she was looking a little bit better. And especially hygienists, you know how that feels, right? Like, yes. So there was a little bit of progress. And then 3 months after that, there was that baby step to like progress again, right? And then 3 months after that, there was even more progress. And that was the last time I saw Diane. Because Diane lost her battle with cancer. I've told that story for 4 years, and I still can't get through it. I can't get through it not just because I lost a patient to cancer, my first patient to cancer, not the last, unfortunately, but because I'll never forget the day that Diane's little brother came back in and tried to explain to me how he would never see his sister again. That I will never forget. And that kind of started me down this road of, we have an enormous responsibility and opportunity and privilege to be able to be a part of these people's cancer care. And not even be a part of it, but potentially prevent extensive cancer treatment or catch cancer early. Let's talk about some statistics. Cancer in the US, 12 million people will be diagnosed with cancer. 12 million people will be fighting cancer. And that's not even the people who are in remission. They're expecting a worldwide jump by 75% by the year 2030, and there are several reasons for that. One, aging population, we know it, right? Our baby boomers are getting older, and as our bodies start to wear out, we do get disease process, and that includes cancer. But lifestyle cancers are actually blamed a lot for this new cancer thing, like all of these cancer diagnoses. So I'm going to explain what is a lifestyle cancer and what in the world does it have to do with dentistry. Lifestyle cancers are cancers that the risk is increased because of lifestyle choices we make, all right? We choose, as a whole, as a country, actually as a world, but we choose to spend more time in the sun than we ever did before. And because of it, the biggest lifestyle cancer is actually skin cancer. Like 1 in 5 Americans have skin cancer. If you kind of bundle breast, colon, and lung cancer all in a big group and take all those numbers, it still doesn't hit the number of skin cancers that we have. Tons of skin cancer. 3.5 million annually, and that's talking all types of cancer, so basal cell, squamous cell, melanomas. The thing about skin cancer that affects us is, I know we don't often do it, but we should be looking at our patients' faces. And we'll talk about that in just a second. So we have a lot of skin cancer happening around the lips, and these are things that we should start looking for. The reason we are seeing in more sun is it's a lifestyle change. So 100 years ago, if you were tan, you were what? Yeah, poor. You worked on a farm, you worked outside. Nowadays, if you're tan, what does that mean? It means you don't have to do anything except for lounge by the pool all day and drink Mai Tais. It's much more socially acceptable to be tan. Thus, we are in the sun a lot more, thus more skin cancers. Let's talk about some other lifestyle cancers or lifestyle issues. Drinking alcohol is a lifestyle choice. I'm from Wisconsin, so I make that choice all the time. Mouth, pharynx, larynx, esophagus, liver, colon, rectum, and breast cancers are all cancers that the rates are increased with drinking alcohol. Okay, drinking alcohol is a huge factor when it comes to cancer risk. Obesity is a huge problem, not just in this country. Esophagus, pancreas, ovarian, and you can kind of read the rest of the list. So it's a pretty significant list of cancers that obesity contributes to. Cigarette smoking, no one's going to argue with me, right? Cigarette smoking is a lifestyle choice that we know increases risk of certain types of cancer. Mouth, throat, lung, kidney, bladder, so on and so forth. So you see a trend. You see what is at the top of all of these lists. So oral cancer becomes part of lifestyle cancers, or it's really linked to lifestyle cancers, because a lot of the lifestyle choices that people make that increase risk cause some type of oral cancer. Make sense? All right, some statistics for you. As of January 2017, the Oral Cancer Foundation stated that over 49,750, so almost 50,000 people will be, Americans will be diagnosed with oral cancer. How they come up with that number, I have no idea. But 9,000 of those people will lose their battle with cancer this year alone. And the statistic that's most sad and amazing to me is one person dies every single hour. So in the time that we spend together today, 4 to 5 people will lose their battle with oral cancer. And the crazy thing is, I believe there are 2 things that we're failing to do that could completely make those numbers different. In fact, did you know that there is only one cancer that isn't making at least some small progress as far as their cancer statistics? Just one cancer. Everything else is making strides. Do you know what that one cancer is? Yep, oral cancer. And there are a couple of reasons for that, and we'll talk about those reasons. But before we do, I'm going to play a little game. And I need you to play along and be nice. So I'm going to make like 4 statements. And I want you to raise your hand when that statement applies to you. Now, assistants, administrative team, this won't apply to you. Doctors, I want you to answer it, how it applies to you, and how you think it applies to your hygienist in your practice, all right? And I want you to be as honest as possible. And to have that happen, I need everybody to close their eyes. Okay, so I mean everybody. Eyes closed, all right? Raise your hand when the statement applies to you. I do head and neck exam, oral cancer screening on every single patient, every single time, so help me God. Raise your hand. Awesome. I do head and neck exam on people with traditional cancer risks like smoking, chewing tobacco, alcohol. Raise your hand. Okay. I do head and neck exam when the doctor isn't making me late and I have time for it. Raise your hand. Did I mention I pick on the doctors a little today? I do head and neck exam periodically only when I think of it, a couple times a year when I'm feeling ambitious. Raise your hand. I haven't done an oral cancer screening head and neck exam on a patient since I left dental hygiene school. Please raise your hand. Okay, and you can open your eyes. Let me tell you what just happened. It doesn't matter if I'm lecturing to a group of 25 hygienists in a little bitty room or almost 800 in a yurt, this looks like a yurt to me, in a dome. It all looks the same. Do you know that statistics have shown, and I've read 3 articles that have said this, do you know what percentage of hygienists are doing head and neck exams regularly on patients? Do you know? Under 25%. Under 25%. So what I see in groups of any size is a few people will raise their hand to, yep, I do it all the time. It is part of my protocol. It is what I do. More people will raise their hand to, oh yeah, when that patient comes in and I'm like, whew, I'm going to do oral cancer screening because they need it. A lot of people raise their hand that they're just not doing it, or they do it so sporadically when they get a chance. Doctors are usually pretty good about coming in and doing an oral cancer screening, but I'll tell you, not all dentists are doing oral cancer screenings at their yearly exams. So what does that look like for the patient? I'm going to pose this question. Who should be on the front line of oral cancer detection in practice? Who? I heard both. I heard dentist. How many of you think it's the dentist? Okay, let me tell you the problem with the dentist being on the front line of oral cancer screenings on your patients. They come in. It's their yearly exam, all right? You've waited for them for how long? No, I'm kidding. I won't pick on them that much. Okay, so they come in, and they ain't really got nothing going on, right? So they stay with the patient, chat about fishing, talk about the kids, look around, and then they finally leave. Is that what really happens? Is that what the dentist is really doing? Yeah. This row is like, absolutely. So while the fishing conversations are going on, let me tell you what's happening. They're looking for cracks, breaks, decay, abscesses, need for crowns, bridges, dentures, partials, implants. They're helping you look for disease. They're checking their periodontal condition. I'm missing a bazillion things, dentists, right? I mean, that's just the tip of the iceberg of what they're looking for. And you don't want them there because they're making you late. So you're like this. And they're looking for all that stuff, and you're like this. And you want that person to be the front line of your cancer detection in your practice? That's not good. That's not good protocol. Dentist, do a flippin' exam every single year. Okay, just come in, make sure you're doing oral cancer exam. But hygienist, you are the front line. We are the front line, okay? We need to be looking at every single patient. We have an enormous opportunity to catch cancer early. Like 60% of the people in the United States actually go to the dentist, at least sporadically. So we have a huge opportunity to catch cancers early. Are oral cancers typically caught early? No, they're not. They're usually caught in like stages 3 through 5. They're usually caught late. And there are a lot of reasons for that. Hygienists, when I ask you, why did you stop doing head and neck exam? What do you tell me? What's your obstacle? Time, right? Absolutely. And I'm going to tell you how this happens. Dentists, you'll probably appreciate this as well. Hygienists will definitely. I'm going to tell you a story of what has happened in dentistry and why we have kind of taken that and taken it off of our plate. Because, by the way, head and neck exam is the first thing that comes off of our plate. Of the things we were taught that are so important in hygiene school, and we stopped doing it. Remember back, okay, so think back to hygiene school. For some of you, it's not very far. For some of us, we have to really think back. But think back to, really put yourself in that place. Most hygiene schools are 2 years, or some that are 4, but most of them are 2. So let's just say you're in a 2-year program, and you are in your last, let's say, month or 2. Let's just say last month of hygiene school, right? And you got all those newbies, those first-year students kind of walking around, and they're taking like 18 appointments to do prophy. And you're walking around and you're like, yep, I'm amazing. I can do a prophy in 3 hours. 3. You got nothing on me. Like 3 hours. We leave hygiene school doing 3-hour prophies. And then we go into private practice like the next day, and we're like, oh my God, how do people, this is not what they said it was going to be like. That's how it is. Time is a huge issue because we don't have 3 hours to do prophies, right? How many, if anybody has 3 hours, I'm coming to work there. No? We have maybe 60 minutes. And so things start coming off the plate. What I'm telling you is we have to put it back on the plate. Now, I'm not talking those psycho head and neck exams that we did in dental hygiene school, the ones that actually took like an hour. You don't have an hour to do a head and neck exam. How long does it take to do a really good head and neck exam? 5 minutes? That's a really good head and neck exam. Less than 5. 2 to 3 minutes. 2 to 3 minutes, because we know where to look, right? Please tell me we know where to look. Where are the areas that have the most cancer? Lateral borders of the tongue, right? Under the tongue. We know what to look for. And so there is a way to actually do a head and neck exam that doesn't take an hour. And so find a way to reincorporate. Hygienists, if you go home with nothing else today, nothing else, and learned nothing, but go right into your practice and do head and neck exams, my job here is done. Like if you do one thing, do that. Do you remember when cancer risk was easy to spot? Yes. Oh, yes, absolutely. Hold tight just 1 second.
My question is about, I know you were talking about barriers like time-wise, but there are some practices that actually charge for this head and neck exam.
Yes.
So pricing can be a barrier as well.
Absolutely.
For a patient to receive that.
Now, do they charge for the head and neck exam, or do they charge for like where they bring in some type of technology, they'll do some type of other cancer detection?
Yes.
Yes.
Like Visalite.
Exactly. So what the patient's actually charging for is basically the Visalite or whatever detection tool, but that does become a barrier, and you're right. How many of you work in a practice or know someone who works in a practice who charges for the head and neck exam? So here's the hard thing about that, and you're right, it is a barrier because most insurance companies, have you found success with insurance companies paying for the head and neck exam? Oh, yes. Yes. Experiences, everybody else who raised their hand, yes. So, and not everybody has dental insurance, but thank goodness, because the last thing I read is that insurance companies are not great about covering those procedures. So you're right, that is another issue. And then it comes down to education, right? It comes down to really amplifying the understanding of your patient of what this is for, what this is actually doing. Hygienists, people don't like doing the head and neck exam, right? They don't love doing it. Why, I have no idea. And when they do it so stealthy. Like they don't want the patient to know. They like sneak their cancer exam in. And I'm very blunt about my cancer exam. I know that's probably hard to believe that I'm kind of blunt, and I do it in practice too. I tell my patients it's a great lead-in for patient education. But great question, and you're right. That does become a barrier, and then you really have to educate and help the patient understand why we're doing this head and neck exam. So let's get back to this guy. I actually have seen him. I mean, minus the earring, this guy's come into my practice in Wisconsin all the time. There used to be a day where cancer risk was like obvious, right? They'd come in, you could smell them. You knew that they had chugged some Jack Daniels and smoked half a pack before they even got into your practice. And you see them and you're like, oh, people raise their hands and they're like, oh yeah, if I know that they have traditional risks, I'll do head and neck exam. The thing about this person, they're smokers, chewing tobacco, heavy drinkers, and this is what they look like. They're usually, 90% of them are squamous cell carcinomas in stages 3 through 5, like we talked about. It's typically not real early stage. And the average age is 62. So if we're only screening people and we're only doing a head and neck exam on this person, it's a demographic of people who we're kind of spot checking. Oh, here, wait, before I do this. Most of these people, by the way, where do we find the cancer? Sides of the tongue, lateral borders of the tongue, under the tongue. They're places I can see, right? So if I actually do my head and neck exam, I can actually see where it is. This is today's risk. This is our new risk, right? And so when this person comes walking into the dental practice, no big warning sirens go off going, oh, cancer, oral cancer risk, right? You just don't see it. Because of the human papillomavirus, it has completely changed the way we see cancer risk, oral cancer risk in the dental practice. 79 million Americans are currently infected with HPV. And so I've sat in audiences, I'm kind of a CE junkie myself, and I've sat in audiences where I'm like, they're not talking to me. That's not me. I remember talking about treating AIDS patients, and I remember thinking, and I would tune it out. They're not talking to me. That's a different group of people. It's a different population. The interesting thing about HPV is you don't get to do that. If you have sex, which I suspect that many of you do, here and there at least, if you have ever had sex in your life, you stand the risk of having HPV. In fact, if you looked at the CDC information about HPV last year, they would have said, by the time you're 60, you have an 80% chance of having HPV. If you look at what they state about HPV this year, they will say nearly every single sexually active person will have an HPV infection in their lifetime, period. So this is in someone else. And this is kind of what it looks like. Now, I don't know, this is my big clinical image. Most of them you don't really need to see, but this is a young man. He's 40, so he's super young, right? Right? Thank you. So he's super young, and he's 40, and he has, I think it was like stage 3 oral pharyngeal cancer in the back of the throat, where we're lucky, because where do we find, not always, but where do we find oral pharyngeal cancers? Larynx, pharynx, esophagus, voice box, tonsils. So if we see it, we're lucky that we can see this during a head and neck exam. So this was actually an image from a gentleman that I'll talk about later. His name is Dr. Dennis Abbott. Anybody ever heard of him? He's a dental oncologist out of Texas. Amazing guy. Anyway, this is one of his patients. Super healthy young man, never smoked, never used chewing tobacco, wasn't a big drinker, and was really healthy. How do I know he was really healthy? Because 2 weeks before this picture of his oral cancer was taken, he did a triathlon. He's an active triathlete. And people who do triathlons, to me, are relatively healthy and a little bit crazy, like a little not quite right. All right, so what do we know about HPV? How many strains of HPV are there? You know, it depends on what you read and when it was actually, when it was written, but they keep finding more and more HPV strains, and it's up to like 200 strains of HPV. So before you freak out too much, let's whittle that number back a little bit. So there's 200 strains of HPV. For those of you who saw the session last year, you got some of this information. Of that 200, 40 are mucosal strains. So they're found in mucosal tissues. So most of them are kind of irrelevant, right? They cause little skin tags, skin wart, like not a big deal. But 40 of those are mucosal strains, and they're found in mucosal tissues. Of those 40, only about a dozen are high-risk cancer-causing strains. The rest of them are very low risk. So again, as we're narrowing it down, we're only looking at about 12 strains that really do the most damage as far as what we see as far as cancer-causing strains. Here's some of them. In this number, there are some that actually they don't cause cancer, and we'll talk about those in just a second, but most of those cause cancer. 18 and 16 are still the most common causes of any type of HPV-related cancers. That means cervical cancer, oral cancer. These are the two biggies. 6 and 11 are HPV strains that affect mucosal tissue. However, these two don't cause cancer. Does somebody want to tell me what 6 and 11 are? And don't tell me canines, because I already know that. What is 6 and 11? Yell it out if you know it. No one ever does. No one ever yells, it's genital warts. No one ever admits, even if you know, you're like, oh, I ain't going to say that. They'll wonder how I know. So anyway, 6 and 11 are genital warts, and just so you know, for the record, genital warts don't actually cause cancer, but they cause this thing called genital warts, which are highly unpleasant. I don't know. That actually I don't know from experience. But I do know they're gross looking because I've done some research. What I will tell you about genital warts that's kind of interesting is they've been doing some studies on young people, like young people, teenagers, preteen, and those genital wart numbers are going up really fast. Actually, that stands true for most HPV sexually transmitted strains, is our preteens and teens are becoming a bigger population. They used to say, oh, men in their mid-20s, it is kind of equal opportunity, and younger people are actually getting diagnosed with oral pharyngeal cancers. There is another population that is second highest risk for these increases in HPV, sexually transmitted HPV strains. Do you know what that population is? What's that? Yeah, absolutely, over 60. So the over 60 bunch is a huge population of people who are having more and more HPV-related infections. It's because we're living longer and we're healthier. And they have this pill, this little pill. So there are things that keep those activities going. And imagine this. You've been with the same partner your entire life, and that partner is no longer with us. And 5 years later, you decide to enter the dating pool. And 60 years ago, you were educated you had sex ed, but sex ed 60 years ago is very different than sex ed today. That is why the Villages, do you know what the Villages is? It's a community, it's a retirement community in Florida. They had to bring a sex ed expert into the Villages because there was a crabs outbreak among their people. So what happens is you have this population of people who have been very safe. You have these women who have had hysterectomies, so they don't need protection. They don't think they need protection. These people are getting HPV infections. All right. When you guys get your handouts, there are going to be some little blanks. This just gives you an idea of how many of these type of cancers are HPV related. So cervical cancer, we are now seeing over 95% of all cervical cancers are caused by HPV. And again, vulvar, why I can't say that, vulval, that's a car. Vaginal cancers are 75%. Penile cancers are up to 63%. They're actually saying that now oropharyngeal cancers, it was just a couple years ago, they realized that more than 50% of all oropharyngeal cancers were caused by HPV. Now they're saying it's about 72%. And how do they know this? Because when somebody's diagnosed with oral cancer and oropharyngeal cancer, they test every single one to see if it's HPV. Why do they test? I mean, we of course want to know, right? But why do they want to know? Do you know? The only good thing we can say about HPV is when that person goes into their cancer treatment, they're finding that the cancer treatment is much more successful. It's the one good thing we can say about HPV. Okay, so I have some frequently asked questions that I'll just kind of spit out some answers for you. How do you know you have HPV? Most of the time you don't. HPV is typically asymptomatic. When there are symptoms, they're kind of like common cold symptoms, so you don't know you have HPV. So you can see how easily HPV can spread. How long does it take to fight an HPV virus? That all depends. They're studying HPV like crazy, and there's a lot they don't know. For most people, it's a couple of weeks. Your body does what it's supposed to do. It fights the infection, and you're good to go to pick up your next type of HPV. But that's how it typically works. For some people, it's months that your body is fighting. And for some, the rare people, it's years. And those people have a higher chance of having that turn into cancer. And how does 16 and 18, or do HPV 16 and 18 always cause cancer? Thank God the answer is no. So even if you were diagnosed with HPV 16 or 18, it's not a cancer sentence, all right? A small proportion of people actually develop cancer from an HPV strain. And how does it cause cancer? So I have to ask this question, so I'm going to tell you how HPV causes cancer. I'm hoping maybe the people who were here last year got a little taste of it from a dentist. Do we have anybody who's like a cellular biology undergrad? Anyone? Oh, thank God. Okay. So I'm going to do my best to take this to a cellular level to give you an idea of how this works. Understand I'm not a cellular biology undergrad. Okay, so HPV virus enters the body, right? So you have whatever type of sexual activity you decided to do to get this HPV infection. It enters the body, and our bodies are incredible things, right? They're incredible machines. And our bodies have defense mechanisms, defense features that protect us against viruses and other things. So the first thing our body does is it typically attacks viruses, right? It goes, you don't belong here, I'm going to attack you, and then it goes away. But there's part of the HPV virus that makes proteins to encode it, and what that means is it's like a cloaking device in your body. So your body's like, no, you're all right, and it keeps it around, even though it shouldn't. Our second defense that our body have is our cells have regulators that prevent excess growth. I call it a governor. Do you guys know what a governor is? They put it on like go-karts so your kids don't kill themselves going like 1,000 miles an hour on a go-kart. It's a regulator. And so our bodies have these internal regulators on our cells, and so our cells reproduce and divide normally at a normal pace. However, two of the proteins that are made by the high-risk strains of HPV interfere with cell function that prevents excessive growth. In other words, so HPV virus comes in, now the body looks at it as a non-threat, and now it renders our body's ability to control that multiplication of cells completely useless. Make sense? And then finally, the body tends to kill foreign cells before they can reproduce. It's just another great feature of our body. However, the HPV virus prevents cells from causing cell death. So it has this it has a mechanism that just allows it to stay safe and then continuously reproduce. And so when your cells have the ability to continuously, outrageously reproduce out of control, what is that this kind of start of? Cancer. Here ends my cellular biology talk for the day. If you want a really awesome explanation of how this works, this is Dr. Dennis Abbott. He's the dental oncologist out of Texas. He treats 95% of the patients who are referred to his practice are oncology patients that are referred by the oncology teams in his area because he's developed a relationship with them, and they work together to help these cancer patients. He's an incredible person and does great things for cancer patients. I've heard him explain this process, and it's like amazing. So there's his phone number, and there's his cell phone. If you want a really good description, you give Dennis a call. I tease, and I actually put his information up there. If you are running it, especially dentists in the audience, if you have a cancer patient, you're running into some struggles, you're having some complex treatment plan issues or complications after cancer treatment, seriously, email Dennis. Say, hey, Catrice said I could email you. This guy is a wealth of information for treating your cancer patients in your practice. All right. Yes. Oh, you guys want a break? Everybody's like floating.